it's my pleasure all today, and I'll be presenting the data collection together with Dr. Marina Ďanželová. To start with the session outline, we will be talking about basic concepts of data collection, data types, quality, collection sources, and then we will briefly present about TB recording tools, both as well as electronic and paper-based collection tools used in Georgia. And finally, we'll have a small class activity regarding it. So before we begin, maybe someone will briefly explain the difference between data, information, and knowledge. Yes, just shortly, if anyone would like to briefly.
You can concentrate on data and information.
Please.
Data are the raw facts, figures. Information is the processed data. And knowledge, when we use this information to tell a story, for example, or to make assumptions or conclusions.
Great, that's perfect. Thank you so much. So to begin with the difference, that's pretty accurate. And again, data isn't information and information is not knowledge. We all know that. And this time it is quote from 𝗵𝗿𝗲𝗿𝗲 and 𝗵𝗲𝗿𝗀. So data is a discrete elements like names, numbers, words, and so on, which that categorize, calculate, and quantify. Yes. For example, in this sentence, like 𝗵𝗿𝗲𝗿's name or the words in this quote, these are data until they are aligned in sentence, and we get the information of who the 𝗵𝗿𝗲𝗿 is. On the other hand, oh, sorry, I did not. Yeah, sorry. So the information is a linked elements like concepts, ideas, and questions that contextualize, compare, connect, filter, and frame, right? In this case, it's like connecting 𝗵𝗿𝗲𝗿 to this quote and adding additional questions like who 𝗵𝗿𝗲𝗿 is and which 𝗵𝗿𝗲𝗿 said this quote, for example, right? And the knowledge is organized information into chapters, conceptual frameworks, works, and facts. So if we go deeper and search who 𝗵𝗿𝗲𝗿 is and find, in Wikipedia that he's an astronomer and this quote is truly his, then we have already knowledge of who this person is, and this quote is rightly attributed to him. Yes. So again, a data element is a recorded event. The data is a aggregation of and represents this data element. Then we should make get the information from the data, which is information is organized data into reference and to a context. And finally, we have knowledge, which is when information is analyzed and communicated and acted upon, it becomes knowledge, right? So data on its own, these are raw facts that must be processed before getting meaningful. They are the lowest units of information from which other measurements and algorithms can be performed, but still data are among the most important and vital aspects of routine and health information systems and research studies. So before we discuss the source of data and information and the quality and of collecting and the process of collecting high quality data, let's not forget that there are basically two types of data, which are qualitative and quantitative data, right? So qualitative data, these are categorical data that are like words, images, observations, conversations, and photographs, and it answers questions of how well, right? And on the other hand, quantitative data are already numerical data, and it measures how much or how many. So some people still think that quantitative data are more useful than qualitative, but in reality, they have a different usability. For some things, quantitative data are more usable, like the trends of prevalence and so on. But for other things, qualitative is more relevant, like why do people not come to the clinic for diagnosis or so on, right? And also, quantitative data is harder to develop, but it becomes easier to analyze later, while qualitative data is like less structured, it's easier to develop most of the time, can provide rich data, but sometimes it's challenging to analyze. If you need to know whether the program is meeting its objectives or if it's on track, what you do is like look at your program targets and compare them to the actual program performance, right? This is analysis. And analysis answers the questions of if my program is meeting its objective, if it's is TB notification rate decreasing in my facility, and what is the percentage of bacteriologically confirmed cases, and so on, right? And the process is pretty simple. It looks like that. In this case, we have input like raw data, then we need to process its analysis, data analysis, and our output is the information that we get. So the information is collection of facts organized in such way that you have additional value beyond the value of the facts themselves. So in addition to the data you have, the raw data, you get some additional information. And this is the data that has been already processed and translated and transported to reveal the underlying meaning. And valuable information has some characteristics, and this is accurate, complete, economical, relevant, flexible, reliable, simple, accessible, timely, verifiable, and secure. Yes. Okay. And finally, we have knowledge, which is information which has been intellectually processed by human or by machine. It has immediate value without any further processing, and knowledge is used to interpret information. Yes. For instance, you have found a higher percentage of your TB patients being HIV positive in the last quarter than in previous quarters. So you have this data, you analyze it, you get this information, and finally you need some knowledge to find the possible reasons. Yes, it might be, for example, more TB patients have been screened for HIV in the last quarter than in previous quarter, or maybe some time ago you had some awareness campaign on importance to report symptoms of cough among sex workers, or maybe there's true increase in HIV prevalence. So knowledge helps us to define the real reasons and get the real information. After analysis and knowledge, we have the interpretation, that is using the analysis for further explore your findings and understand the implications for your program. In many cases, this means that to get the right interpretation, we need some additional information to be found. For example, it is in some cases it's vital statistics or population-based surveys, or some additional information is required to gather. So now let's go to go on with the data quality and why is data quality important. So to enhance evidence-based decision making, first of all, and of course to give substance and weight to the recommendations for future actions, right? High quality data will help us to form an accurate picture of health needs, programs, and services in specific areas. inform appropriate planning and decision making, inform effective and efficient allocation of resources, and support ongoing monitoring by identifying best practices and areas where support and correct measures are needed. So we should understand that data collection is not just for feeding information into indicators that need to be reported just elsewhere. It is important to see that it is a tool that decision makers use at different levels to improve their program. So the data quality is measured by reliability, validity, completeness, relevance, and timeliness. Yes. We can identify some symptoms of poor data quality. For example, if different people are supplying different answers to the same question, or the data are not collected in a standardized way, or staff suspects that the information is unreliable, but they have no way of proving it. So these are, you can see here all the different symptoms of data problems. And the key issues are usually validity, reliability, accuracy, response rates, data dictionaries, and missing data rates, right? So to go on with the rules to collect high quality data, first of all, we can always try to use multiple data collection methods. We can always use available data, but you need to know how the measures were defined and how the data were collected and cleaned. You should know also, when using available data, the extent of missing data and how accuracy of the data was assured. Using like available data has its advantages. Often it's less expensive and faster than collecting the original data by yourself. But also there might be some challenges because there might be some coding errors or other problems. Data might not be exactly what you need. So you'll have to like go deeper and finding some additional solutions to make the quality of available data higher. If you must collect original data, then be sensitive to the burden on others, like the people who will be collecting this data. It should not be like too complicated for them. It should not be too time consuming, and so on. So always protest the forms that will be used for data collection. Establish procedures that follow them, like protocols for data collection and so on, and maintain accurate records and definitions and coding, and verify accuracy of coding, and also have structured approach. Besides types of data we discussed, data can also be defined by the type of levels that they are going to be collected. Yes, and we have some patient level data that are bio data and health facility level data, while also we have community level data, regional, district, or high national level data. And it can also, another way to categorize TB information is based also on the frequency of data collection. And here we have like routine, which is also called continuous data collection, and non-routine data collection. So routine data collection refers to data that are collected continuously through process and reported more often than annually, usually, while the non-routine data collection refers to data that are collected on a periodic basis, and periodically is usually less frequent than annually. So these are non-routine data are usually the surveys, studies, and so on, while the routine data are the health facility-based information, statistics and patient information, as community-based, and so on. The facility level data includes TB register, TB treatment cards, laboratory registers, stock cards, and so on. And to ensure the quality of data at the facility level, it is important that these cards should be always filled out like same way, correctly, and they should be filled out same way. What it often requires is easy to use cards, trainings, frequent reviews and monitorings of nurses and the personnel who is filling these cards, and communication with them why it is important of filling these cards correctly. So here also we have some slide about data sources, and we can see here that there are a lot of different data sources that TB data is collected to. Sometimes they cover each other, sometimes they include same information, but like to tell the truth, there is no single source that can satisfy the needs of TB-MNE in general. So before we go on with the discussion on what are the common recording tools used in Georgia, would you like to also briefly present what are the common tools used for TB data collection in TB program in your country? Yeah, please, if you can, like we can go country by country. You can tell just electronic tools or paper-based forms. What do you use in your country for data collection?
В Армении у нас и
In Armenia, we at the same time have electronic and paper form. So the validity of data is checked by comparing paper form and electronic, and this is done on outpatient or primary healthcare units and on administrative or program level. So we use both. I have a question. Does anybody have a fully electronic form? We have full electronic reporting. We don't any longer have a paper reporting, but for collection of data, the form are still electronic. How far is the time when these paper forms will disappear and everything will be done electronically? What is the main obstacle for that in your country? Computer literacy, or is it better to have those electronic or paper forms to cross-check? Because in that case, we have kind of double entry. Yes, this data are, but this in the process of translating, there might be some, could be some, you know, the electronic tool that we have is a TB manager, which is used by other countries as well, some other countries as well. And so a couple of, or 1 year ago, we upgraded it and many modules were added, but when it is upgraded, it is quite difficult and energy and time consuming technical process to upgrade or update some electronic tools. So sometimes it is easier to start from scratch rather than upgrade something that you have. If it is gradually changed, it is quite difficult because you know, you add one information and something else disappears, and these links should be kept very closely. So the process took almost a year, process of upgrading. Talking about paper forms, a lot of information, not only but recording is done based on this electronic data in polyclinics, for example, etc. And we know that, but we know in electronics, there are some technical problems like servers, etc. And if something is lost, we will not have any backup in paper because well, not necessarily, because Irakli has already mentioned this.
Backup strategy, right?
Yeah, but это тоже техническая проблема. Я говорю, это серверы.
But this is also a technical problem. Backup is against servers. It requires investment. So what are the opportunities and what are the limitations? And we know that we have financial constraints to have a very good electronic system with backups of the data, etc. They should be taken into consideration. If this is done with the highest quality, maybe no data will need to be backed up. But the other is the other issue is integration in national health system. But there are also problems in some countries. In our country, for example, this tool is more financial rather than a tool which to which you can input a lot of information and receive some output, because output is also very important. So these kind of issues should be taken into account. And of course, political will of the country, of the government, of the national program, just to move in that direction. Thank you. Yes, because when from the paper carriers, the data is transferred to electronic systems, I think there might be a lot of errors, and there are purely human errors that can be corrected by validation, but there are errors which are not just typos, but
Reporting purpose, or that's
Но знаете, хочу добавить еще одно из моего бывшего.
But I would like to add something from my experience. When you have an electronic database, so one operator is also a mistake, because we need two operators for cross-checking, and this also should be taken into account.
Okay, so I'll continue.
Thank you very much.
Usually there are two types of the data collection tools. One of them is paper-based and other electronic-based. In paper-based, we have all these cards, forms, and registers that are used for TB program. And for electronic-based, it could be like any technology-aided platforms that are designed to collect information on TB, like eTB Manager, local TB HIMS systems, laboratory management systems, GX Alert, and so on, right? So types of electronic systems that are used in Georgia, and we have like a number of electronic systems. Some of them collect, some of them duplicate collection of the same information, and mainly these are the National TB Electronic Database, local HIMS system, which is used at NCTLD only at this point. We have also National Reference Laboratory database. We have a video-supported treatment application and contact investigation and TB treatment application. We use C360 software for GeneXpert system monitoring. We have 𝗿 system, and also now we are piloting new TB electronic database. And I will shortly, briefly discuss each of these tools. I won't stop all the current TB database which we are using right now. So mainly this database collects the paper-based forms are collected from each facility, and they are redirected to the district or regional level where it's segregated, and then it is imported in the current database. So as I said, we are piloting the new database which should replace this one. And I will elaborate more on this on the following slides. But first, like, I will start with the GeneXpert system monitoring software, which we use in the country, and 𝗵360 is a disease surveillance and system monitoring software. It's like cloud-based secure platform and allows to track the epidemiology and monitor TB data by each region or each facility or each system. So what is generally used, you can check the number of tests for each GeneXpert system and number of confirmed cases and so on. So you can monitor every GeneXpert system and how well it is utilized at that facility where it is installed. So
Who else uses this thing? Because you guys all have GeneXperts, right? And lots of them.
So it is probably same like 𝗔𝗋𝗋𝗿. Do you use 𝗔𝗋𝗋𝗿 systems? It looks like the same, like 𝗔𝗋𝗋𝗿.
And it's also free, right?
Yeah.
It's by Cepheid, or no?
It's not developed by Cepheid, but it is strongly accessed. Yeah. So also this program is used to have like support section, technical support section, and here you can monitor the error rates and invalid results from each facility. And for example, you can evaluate you can monitor the error codes by their type, and you can understand whether is this what is the reason for those errors. So if it's like laboratory staff, they're not preparing the sputum well, or they are not storing the cartridges well, you can understand that, and you can understand that you need additional trainings for those laboratories and so on and so on. Right. So another system we have is a video-supported treatment application called 𝗿𝗲𝗿𝗲, and in 2016, when it was developed, high loss to follow-up among DR patients was identified as one of the main challenges in national TB response in Georgia. So one of the steps was to develop locally as a video-supported treatment application, which collects and aggregates data on those patients who use this application. Because also in Georgia we use other kind of video-supported treatment using Viber and WhatsApp and other common tools, but this one collects data about those patients who use this application, and you you can download the raw data in Excel, of course, and also there are like different dashboards indicating number of patients on ongoing treatment and completed treatment, and adherence statistics on each medicine and so on. Yeah, sure.
Yeah. With the video-supported treatment systems, we know that you have VSD, right? You have the same. How it's going, by the way? Okay. All right. And in Ukraine, you use multiple systems, right? You use Skype, Viber, WhatsApp, but there is no custom developed the mobile application. No.
In USAID project in some regions, but not countrywide.
Okay, so the next platform that we use, electronic platform, is called 𝗿𝗲𝗿𝗄, and it is a platform from electronic registration of contacts of index cases and for persons with LTBI. And the purpose of this platform is to record all contact and persons with TBI through the country. So this platform was also launched last year, and it collects all the information for contacts and risk groups also. And here also we have some raw data Excel export option, and also we have some statistical dashboards showing the number of TB patients by facility, region, or city, also the contacts, and all this information listed here. But like I just wanted to add that before this electronic system, there was no electronic system available that were registering TB contacts and risk groups. It was only done on the paper-based forms. And on this slide, you can see that on the left side, there are different tools, both paper-based and electronic, that are used in Georgia for collecting TB data. And on the upper side, there are some different data. And for example, we can see that presumptive TB cases are collected in TB registration log, which is paper-based journal at each facility. And you have also medical record for patients where you get this information. And this information also, I don't know if it's like wholly getting there, but it's also getting in its system. And also, for example, TB confirmed cases, you can see that all these patients get in all these tools and paper-based tools. So well, I just wanted to show you that there are multiple tools that can collect and gather information on the same indicators. And every time you should know where to cross-check, what to use as a source form, and where can be to identify, where can this be identified, right? Our class activity will be kind of the same, about same questions, but we will get to this later on. And finally, the new TB electronic test database. So this database was developed last year, and we are now piloting it throughout Georgia. For the pilot stage, the 7 biggest facilities for TB will be included, and we tried to make it like one general database where all the information will be collected. So firstly, it will be linked to all the other electronic tools. At this point, it is linked to the video supported treatment application and TRACE-TB contact investigation application. But gradually, we are planning to link it to the national laboratory database also, and the information from like current database, it is also transferred to this new database. So also this new database should generate reports automatically. So all these reports that are reported at national level or like to WHO or so on, it will have ability to produce those reports automatically just with one click, selecting like time range, and then just with one click you will have all these kind of reports. There are about 30 different forms included. It will be filled at a facility level, so each doctor will be importing the information for their patients, and the laboratory will adding their information on tests and so on and so on. So each user will be adding information in this database based on their roles. It will be level mode, and of course it will also include some raw data in Excel and some statistical dashboards. Yeah, so I think that's end from my part for electronic parts. If you have any questions on electronic systems, I would be happy to answer. Otherwise, I'll ask Marina. Yeah, sure.
When you said it's being piloted
now,
when are you expecting it will actually be not piloted, rolled out, where doctors and nurses will actually be entering data into the system? So that's my first question. And then my second one is, which is like the second step, when do you expect to not be using those big paper registers?
Okay, thank you. So the pilot should be over, and we should start using this tool from the end of October, something like that this year. Because we had one small pilot in the beginning of the year to identify some bugs and issues. And now we have another pilot where more facilities will be involved. It's kind of not like pilot, but it's still like that. Somewhere from end of October, it should be used regularly as the main database for the country. About paper-based forms, I think Marina can answer this better, but I believe we will still be using paper-based for some time. It will be still required for some cross-checking and analyzing the data quality that falls in this database. So usually what we did for other electronic systems, maybe for this TRACE-TB, we had this new application where you registered contacts and people, risk groups, people on TB treatment, but we still have this, even though it passed already a year, we still have this paper-based journal that is used to see if something's missing, if something is not reported correctly. So we still have the ability to cross-check the information in the electronic tool. But gradually, of course, the reason you develop electronic tools is that you replace the paper-based tools at some point.
So my understanding in Georgia and maybe the other countries is that the average age of a TB doctor or TB provider is quite old, right?
Yeah.
They're not young people who are probably used to using, very adept at technology. So was that something that you found during, or are finding during the pilot phase, that it's difficult for these providers to fully embrace this electronic system?
Yeah, that's so true. And also people who've been working on the same way for a lot of time, it's always challenging for them to use new tools, even if it's easier to use. The first response is always no, I've been doing it and everything is going well, so why do I need to change anything? But there are some tips that can help your electronic system to be easier for users. For example, selectable fields. Rather than writing fields, you just have selectable fields, and it's easy to find the answer there and select it. So we try to make as user-friendly as it is, but still you need a lot of planning beforehand, a lot of pre-testing, and also training. So after first trainings, you should have monitoring on site to identify what kind of challenges they still have, and then plan refreshing trainings also, and so on. So yeah, it's a little challenging, but I believe it's a better way to collect the data. Okay, so any other questions? Yeah.
I have a question about TB-7 and TB-8. What is mean quarterly registration forms? And what is mean?
Okay, so on paper-based forms, I believe Marina will answer better than me. So maybe, sorry. Okay, thank you so much.
Приветствую всех. Я Марина. Я работаю.
Hello, everybody. My name is Marina. I work in the national program and I'm head of the control and coordination service. I want to say that the strategy that was introduced in Georgia, I've been doing monitoring since then. So after what Irakli briefly told us, we will discuss the paper forms, because we all know that we use the paper forms and electronic forms, and all those forms are WHO forms, and the WHO provides trainings for everybody. We are all trained, we all know how to use those forms, but there are some peculiarities in our country, and I guess in your countries as well. And so let's now share this experience, how we fill them out, why do we need them, what we expect from or what is expected to make sure that these forms are filled out well. So we have this registration log where the contacts are registered. This is the main form of registration of acceptable forms and the treatment of TB. 03 𝗵𝗶𝗿𝗀 is for treatment of resistant TB. 𝗵𝗶𝗿𝗲 is for cross-checking with lab log. TB07 and 𝗵𝗲𝗿𝗲, these are quarterly forms, notification and treatment outcomes. We also have TB01. This is a treatment card of acceptable patient, and also for resistant TB. So I want to say that in Georgia, we have come up with the opinion that quarterly data do not very well allow for individual assessment of patients. So in 2005 or 2006, we had consultants from Emory University, Atlanta, and during the survey, they recommended us a form which is called Form 1012, and all the cases are checked not on quarterly basis, but individually. So for each patient, we fill out the 1012 form. I would like to share this form with you. So 1012, these are three copying forms. So you fill out first form. We call them the basic forms, forms that are base forms, which are then transferred to the database. So first of all, this is notification. We've registered the TB patient, and then we receive the data and fill out the form. It is copied into the next form, because the next notification will be when this case completes treating, and then we enter the data, how we completed the treatment, what is the definition, what is the outcome, and that is all these results go to the database. And this is very convenient to check main logs to make sure that the data are of high quality. So if you want to see, we can look at it, we can go through them.
I just wanted to add, all of you have these forms in the files on your table, in Russian and in English. There are some different forms for WHO, and also the TB 1012 is available there.
На вопросы по ходу презентации или после?
Questions. So you're talking about all the information for notification, yes, about the cases. Is that an online mode from the outpatient? So does this, so in outpatient, can they see that information or not? Well, these forms are given to all facilities, and when they diagnose TB and start treatment, they fill out these forms for every patient. So as soon as, for example, today a TB case was recorded, and here are all the data. And on the district level, in all the regions, we have the database manager. And so it is transferred to the regional base of manager, and the central unit can see this. So on the level of doctor who detects, they do not work with database, they work only with paper forms, and the database works on region and on the level of region and center.
This is how the current database works. For the new database that we are piloting now, it will be different. So TB doctor will be filling all this information in the database electronically.
Мы говорим о том, что сейчас у нас работает. А Ираклий уже вам...
We are talking about current database, but Irakli told you how it will be improved and how it will it be done in electronic form. But so far we are discussing how we came to where we are and how we register, control detected cases, and how important it is to make it to ensure high quality. So for each case, we fill out Form 10. So we have data: who is the patient, in which facility they are registered, and so if it is an inpatient, and then the treatment is continued on outpatient basis. So for each patient, not to lose them, we have individual codes. Maybe this is not that interesting, but it is very important because these codes, they contain much information. So you see this box here. Without this code, our patient cannot undergo examinations. Why? Because when we combine the registration logs, we could see that in 𝗵𝗶𝗿𝗲, for example, we had 10 patients, and in lab log we had 12 or 13. So when the case is confirmed in the lab, they should be transferred to the 𝗵𝗶𝗿𝗲. But we lost 3 of them somewhere. So the question is where? So the patient did not come, was lost for follow. So, or some people just went to lab, just think the doctor. That could be could be linked with some stigma. They wanted to receive treatment in different region, etc. Many reasons. But we knew that we have 3 positive patients in this district. They are not receiving treatment. There were cases when they received treatment somewhere else, and they had no idea that the program supports the patients from the very first day, that our combined drugs are free of charge, that monitoring is, etc. So these problems we still had before 2005 and 6, and that is when we came up with the idea to create this unique code for each patient. But in those times, not everybody had ID cards. We had refugees and IDPs, etc. But now we all have everything, and this code really helps us to look for lost patients. So how is this code generated? It is generated in the log of possible cases. So this is where the first time the patient is registered. So we examined 10, 1 is the positive, and so the code is generated right away. So this is the year, first of all. Each facility was numbered. For example, 01 is the center outpatient, and this is A here. This is a new patient, so we need to know how many new cases we have, how many treated cases we have. So if we have letter A here, this means that this is definitely a new patient. And when we work with the indicator, it is very easy to check with this code. Next is number 005. This is a registration number in the log where this code was generated. And after that, all the examinations are provided, whether this is inpatient, outpatient, or lab. All the data comes not through the name, but through this code. This is really easy, makes our lives easier, because if we look for a patient, and if here we have a number 20, it means that the patient was lost in 2020. In which facility? Here we have 01, which means this is the center. We know this is inpatient, so we know that he's not treated, etc. So you see here, all the main data is filled in here. And most importantly, how TB was confirmed and what definition was given. This relapse or new case. Here we, by all means, fill out bacteriological outcome, positive, negative, or no examination was possible. So GeneXpert is conducted, and we receive answer definitely negative, positive, or no result. Then relapse, the retreatment, new case, etc. So once a patient was diagnosed, it is very important also to know when the treatment was started. Sometimes it happens that we diagnose a patient, but the patient does not start treatment in a week, within a week, and we start looking for reasons. Why, how come that a patient that was already registered as a TB patient does not start the treatment? And there we start looking for the patient and for the reasons why this patient does not start the treatment. And this is the form which is called notification, and so it is then passed to the data. Then when monitoring laboratory data is received, and once the treatment is completed, we must fill out the next form when we have the lab test, and what are the results of the lab test, and most importantly, what is the definition, how this case was completed, what day, what year, etc. All these data are compared with other with the data in other logs, and that is how we check the quality for all the data I list.